Hey everyone, Current ECG here. My name's Dave Klein and I'll be your tour guide for the next couple of minutes or so. And by the end of this episode, I hope to have you all literally depolarizing right out of your seats. Now today I want to talk about a piece of equipment that we carry as emergency practitioners that may be one of the most important tools we have. But how often do we use it? Yeah, that's your stethoscope. You have this stethoscope, it's a tool. We listen to heart sounds with it, we listen to lung sounds with it, and we listen to a lot of other cool stuff. But in particular, we're focusing really on lung sounds, I find, to try and figure out, is there something going on with respect to a disease process that we can recognize in our patients? And those lung sounds and the ability to auscultate them is something we really need to do with practice. To figure out, where am I putting the bell of my stethoscope? What am I listening to here? And so we'll show you some points on that in a second. Now, when I became an advanced care paramedic, so I've been a PCP for a while, and I decided to become an advanced care paramedic, I had this great preceptor, and I immediately started my preceptor shift, and we were doing tons and tons of calls, and I was noticing that my preceptor in the beginning was making me auscultate every single patient I came into patient contact with, quite literally every single patient. And so in the beginning, I was like, okay, I followed along, and I auscultated every single patient, no matter what. And then 3-4 months had gone by and we were doing lots and lots of calls. I mean, you can imagine how many patients I'd encountered, hundreds of them at this point, that I was auscultating their lungs. And so I vividly remember one call. I go for like a 16-year-old male patient, angulated ankle fracture, soccer field. I introduce myself to the patient. I'm conducting my assessment. I'm going through my treatment, trying to limit pain, trying to help with perfusion of the angulated limb. And then my preceptor, let's just call him Steve. Steve said, Dave, you going to auscultate the lungs? I said, yeah, I am going to auscultate the lungs, Steve, and I did it. And so we finished that call. We transferred care of the patient, and I said to Steve, do you mind if I talk to you in the ambulance bay for a second? He said, yeah, sure, no problem. And so we go out to the ambulance bay, and, I'm feeling really sick over this whole thing at this point because I'm not sure why I'm auscultating like this. And so I'm really, really confused. And I say, Steve, why are you making me auscultate every single patient I encounter while I'm doing this preceptorship with you? Is there a reason for that? I said, and I quite literally said this, I said, are you messing with me? I said, because if I've offended you in any way, I apologize. I said, I just don't understand why you're forcing me to auscultate every single patient I encounter, even if the patient has absolutely no complaint of respiratory distress, lung pathology, or anything like that. Why am I auscultating them? I've been a paramedic for a while. Why are you making me do this? Steve paused for a second. He didn't look angry. He just paused. He thought what he was about to say. He looked at me and he said, because you don't know what normal is, Dave. And I thought, what is he talking about? He said, you don't know what normal lung sounds are, Dave. He said, you need to understand what normal COPD sounds like. What is normal bronchoconstriction? What is a normal sort of pneumonia pattern? What are normal other adventitious sounds? He said, until you auscultate every single patient, healthy lungs or not, to get a baseline of what true lung sound should sound like, how could you possibly ever expect to be able to distinguish things like congestive heart failure from pneumonia, which can sound very similar? How could you ever distinguish between like a regular COPD sort of bronchoconstriction pattern with one that's an acute exacerbation? And so that really hit me, and I thought, yeah, Steve's probably right. I said, I don't think I do auscultate enough then. And maybe as practitioners in general, you're listening and seeing this and thinking to yourself, I don't either. And I think that that's an important message that we need to learn to advocate for ourselves and our colleagues to encourage us to auscultate our patients. And I continue to take that sort of learning from Steve years into it, and I felt like I improved the skill of auscultation for myself and felt way more confident at 3 o'clock in the morning when I'm trying to figure out, is this cardiac asthma or is this COPD? And what to look for, because I knew how to use my stethoscope correctly, and it gave me confidence in my assessment and improved my patient care. Not to mention, auscultating can be tough when you're not sure where to put the bell of the stethoscope. And there's all kinds of teaching out there online and in books that can show you some tools for it. And this image here shows this as well, showing you that you're starting in the apices, working toward the bases in sort of a crisscross pattern, but this is giving you a great view of exactly where that bell of your stethoscope should go to try and make sure you're hitting the correct area of parenchyma or lung tissue in order to get the best sound you can. And this is just showing you the front of the lungs. So you're auscultating the front of the chest. But we know the best place to listen to the lungs is on the back because there's less tissue there. There's less muscle in the way. And so that you have a much more direct and clearer sort of ability to listen to air movement in that lung tissue through those main airway structures down into the alveoli. And so, whenever you possibly can, try and listen to the back. And if you can't listen to the back, then use the front, obviously, and try and make sure you put the belly or stethoscope in the correct spots. And remember, this is a skill and a tool. It's going to be even tougher when you try and do it on pediatrics. Right? Everything's a little bit smaller. So you got to practice even more on where are you putting that belly or stethoscope, particularly if you don't practice in pediatric emergency medicine. Well, we're carrying around adult stethoscopes. And so what happens is because that bell of that stethoscope is so large, well, you can kind of get referred sounds, meaning you're hearing one sound in the particular area of lung tissue, but maybe that sound's coming from another area because the bell of the stethoscope is so large, it's hearing things from other spots. And so accounting for that and understanding that is critical as a clinician and learning how to not only auscultate every single adult patient you encounter, but I encourage you to auscultate every single child you encounter in the field as a patient. And so practice that skill and account for the pediatric as well. And until next time, sugar water auction to survive, the eyes can't see what the mind doesn't know. And in Klein's world, who gets an ECG? Almost everybody. Stay current. Hey everyone, thanks for being a part of today's episode. If you'd like to continue your learning, improve your skills, and provide a higher level of patient care, well, come be part of our community. If you're a student who wants to break through in emergency medicine, learn how to work the trucks and the streets, well, this is for you. If you're a seasoned veteran who's like, hey, I need to brush up on my skills, technology's moving forward, so should we, then this is for you. Come join this community at currentecg.com. Let's make emergency medicine education and ECG interpretation a little less scary and a little more fun. Again, subscribe to us at currentecg.com. Hope to see you soon. Stay current.